All right, and welcome to Envision New Mexico. I want to let you know you're in the right place. And we just need to run through a few housekeeping slides in case you're not familiar with Zoom. I believe you've already found the mute button, so feel free to mute and unmute as you will. And you can also start and stop your video if you'd like to start that so we can see you, that'd be great. Otherwise, you can leave that muted. And if you do wish to receive CMEs or CEUs, we just need you to announce your name here in just a few minutes. We'll go around the table also before we do our introduction of our speaker, and just let everyone know who is here. And just another join the conversation slide. Our disclosure and accreditation statements, we're required to post those in order to give out CMEs. And at this point, let's go ahead and do roll call. And just real quick, this is Kevin Whirling, Systems Analyst here at Envision New Mexico.
I'm Andrea Anderson. I'm a QI co-chair at Envision.
I'm Gigi. I'm an undergraduate student. Dr. Chavez.
I'm Heather Pratt-Chavez. I'm the presenter today.
Hi, good afternoon. I'm Courtney McKinney. I'm the program manager for this initiative.
Okay, and if there are no questions, we'll go ahead and turn it over to Courtney for introduction.
Thanks, Kevin. Well, welcome. Good afternoon. Thanks for joining us today. We're really excited to bring you this telehealth series that's presented by the NOW New Mexico Quality Improvement Initiative. Just to give you a little bit of background, this initiative focuses on optimizing care for neonates at risk for opiate withdrawal syndrome. So this is a 12-part curriculum, telehealth, that's designed to give providers, nurses, case coordinators, care coordinators, and community members content-specific training and education with opportunities for case consultation around this particular focus. So I just wanted to take a moment and introduce our speaker today. Our speaker is Dr. Heather Pratt-Chavez. She's an associate professor with the Department of Pediatrics at University of New Mexico School of Medicine, and she's been there since August of 2010. So welcome, Dr. Pratt-Chavez. We're so excited to have you here today. I'll just give you just a few moments to give us a little background on yourself before you get started.
Yeah, sure. Thanks for having me here today. We're excited to start this quality improvement initiative where we're going to set a curriculum and hopefully set some standards and a support network for providers across the state to optimize the care for these babies. This is a challenging population that's growing, and so we all need to work together to take really good care of these babies. So this component of the curriculum today is going to be an overview of how we identify babies who are at risk for opiate withdrawal, and then how we assess their clinical severity and what we do from there. So this will be a section about identification and observation of these babies. So you should have a handout that will go with this talk that you can read along with. It's the Finnegan scoring tool. We'll get to that at the second half of the talk. So the objectives of this talk are that we're going to learn the key points of history for a baby, and that would be the health history of the mom and the baby that will put a baby at risk for the neonatal opiate withdrawal syndrome. We're going to talk a little bit about how the Finnegan tool is utilized and how to best use it. The Finnegan tool will be the tool that we're going to recommend to all providers to use and to plan treatment for babies. We're setting 3 parts of care for these babies: identification, and then observation, assessment, and pharmacologic treatment. So in this talk today, we'll be covering the first 2 initial phases of treatment for these babies, which will be first identification of them and then assessment of the severity of their tool, which will be part of the observation component. So let's just get right into how we identify these babies. Ideally, what we have is when we're presented with a newborn, that hopefully we've had a relationship, a therapeutic relationship with the mother before she delivers in some setting, where if she has a substance use disorder, she has been in a place where she could disclose it and she's getting treatment for it. That's the ideal circumstance. If she has not been enrolled in a treatment program and she has a substance use disorder, hopefully in this setting where you have her with her new baby, you guys can develop a therapeutic relationship where she feels that she can disclose and communicate openly with you about what has been going on with her during her pregnancy, especially if she hasn't been connected to care, if she has care that's scattered across providers, then this would be a great place to start engaging her with a therapeutic relationship. And so when you approach a woman where you're concerned that she has a substance use disorder, we should all remember that substance use disorders do not come out of nowhere. They oftentimes, they're a way that a woman with a history of trauma is medicating herself for some serious mental health issues, depression, anxiety, PTSD. Or she has had some medical interventions that have gone terribly wrong and she's ended up with a substance use disorder. And there's often layers of shame and anxiety associated with that as well. So when we approach women and we understand that we are approaching them knowing they have a history of trauma, it's important our language choices when we talk with them, that we use compassionate language and non-judgmental approaches to their care. And so there's a qualitative study from midwives in Australia, where they identified the barriers and motivating factors that help communication with the care team with a pregnant woman or a new mom who has a substance use disorder. And I like it because the paper lays out these different factors that can increase our comfort with disclosure with these moms. So we can sort of have a checklist in the back of our mind when we're approaching these women and make sure that we are doing our best in each of these sections. So our practice style, we should be deliberate in our non-judgmental and supportive approach. It's very difficult to take care of women who have a substance use disorder when we have strong feelings about the suffering of their baby because of their actions. And I think we all feel that because we see a baby who's innocent, who's suffering, and it's because of the actions of a mother. And so if we can recognize and be aware of that feeling that this this dyad elicits in us, then we can try to redirect those feelings and be deliberate in our supportive and non-judgmental approach. It's very challenging, though. I'm not saying this is easy either. And also, if we can, the non-judgmental aspect really helps to remember that a substance use disorder is a chronic illness, that more and more we are approaching the same way we approach diabetes. And so when we have a mother who has gestational diabetes, we don't shame her and say, oh, you're a terrible person, you ate terribly and you're obese and that's why your baby's suffering. And so we should have the same set of thoughts about approaching a woman with a substance use disorder. It's also really helpful to be very direct. I am worried that you have an opiate use disorder. I think, are you using heroin? Can you tell me about heroin use? And the second section, assessment of substance use, there are structured tools that are well supported for discussing substance use disorder with women, and we will discuss those in some of the other talks about maternal care. But asking very direct and open questions, and then repeating your questions and asking for precise details will elicit more information, more accurate information, and also lead towards creating that good therapeutic relationship with women. Because if you keep asking in a direct fashion, in lots of different ways, it becomes clear that you are really interested in the accurate data and not interested in shaming her. This one can be very challenging in the medical environment, but try to look for some privacy and space for these women and try to find a chance to talk to them by themselves, because there is a lot of overlay with domestic violence and intimate partner violence and substance use disorder and the chaos that goes with substance use disorder, not to mention that women are at increased risk for domestic violence during pregnancy and delivery, even without substance use disorder. Lots of women are nervous about discussing substance use because of the fears about child protective services and removing their children from their care. And I think it's always important to be upfront. Yes, if you have polysubstance exposure during pregnancy, Child Protective Services will be involved. And by the way, we're going to have a specific talk about all of the issues with reporting NCYFD that will cover this in detail. So this is just a skim by this issue. But being upfront that there will be reporting, but also encouraging the families to be open and cooperative, and that will have best outcome for their baby's health, for their health, and also with Child Protective Services. And then, of course, I really haven't met a woman, no matter how chaotic or difficult her life is, whether she has multiple overlaying psychiatric issues, all of them want their baby's health to be good and want the best for their baby. I've never met a woman who wanted her baby to suffer, ever. And so if you come at that angle, like, let's help your baby so they're not suffering and work together as a team, that can be very motivating. The other factor that increases comfort with care and disclosure is if you have continuity. So as best you can in your circumstances, if you can have the same people caring for the mom in these settings, it really can make a difference for them. So that would be how we could elicit a history of substance use disorder during pregnancy. We can also do objective laboratory measures with urine drug screen in labor and delivery or postpartum. Some institutions have very strict urine drug screen protocols and policies. It's good to familiarize yourself with that. Some institutions test every single woman who presents in labor for drug screen. Some you have to inform women and get consent, so it's good to make sure you know what your institution is. If you have a woman who's enrolled in a medication-assisted treatment program, she will likely have very frequent urine drug screening, monitoring the status of her treatment. So urine drug screens reflect a short period of time. They don't reflect months of pregnancy. And so it gives you one other idea of what the substance use history is for these moms. So we have the baby now who's there, so the little newborn, and we want to assess for substance use, for substance exposure. We really use urine very frequently. It's very easy to obtain, and we have rapid results. It would be a bag specimen, so ideally you put the bag on the baby right when they're out and collect the urine specimen right away. The results come back very quickly from the lab, and so they also will reflect a very recent exposure for the baby. So it will only really show maybe up to 6 days of exposure, and that's for some of the methadone metabolites. Some of the limitations of urine testing is that it can be hard to get a sample on a little baby who's newborn, who's kind of a little grubby after being born. You have to get the bag to stick, so it can be hard to get a sample. Neonates don't pee very much, so it can be hard to get the right volume to get an accurate sample. It really, because of these factors, it has a low sensitivity. There's a high false negative rate. So you may have a mom who's disclosing to you, who's telling you, I used heroin 4 hours ago. The baby very likely could have a negative drug screen. And that does not mean that she's lying and trying to convince you that she's using heroin. It means that the baby's test has a low sensitivity. So that's important to keep in mind. So a negative drug screen for a baby does not mean that the baby did not have exposure to opiates. The other testing modality we'll do for infants is to send out the baby's meconium. And notice I did say send out. There, we have to, currently we do not have a rapid meconium testing. So it can take weeks, up 2 to 4 weeks for these results to come back. And so it doesn't have any effect on your acute management of this baby in the first few days of their life. They may already be discharging home before you even get these results. So keeping that in mind, we really should consider what the utility of the meconium screen is before we order it. It's expensive. It may just confuse things and cause issues. It does have very high sensitivity, so it will accurately reflect what the baby's been exposed to. Meconium is created by the baby from sloughing off of their intestinal wall cells into their little intestines, and then also the cellular material that they swallow in the amniotic fluid. So it accumulates slowly over the second and third trimester. And who knows, we don't know when it exactly starts accumulating, and we don't know exactly when it stops. So that does make it complicated to pinpoint a time frame for exposure. For instance, a mother may have had a relapse of opiate use during her pregnancy, but then subsequently has been on her medication-assisted treatment and is consistent with her program. And so that meconium screen may show that she used heroin, but that doesn't mean that she used heroin since she's been on her treatment. So these are the challenges of interpreting these objective tests. The thing about meconium that I actually have found helpful in my clinical practice is that it does show if there has been alcohol exposure for the baby in the second and third trimester. And I find that helpful only in that it allows me to refer the baby for early intervention services. So if there hadn't been a disclosure of alcohol prior and then we see it on the meconium screen, then it makes the baby qualified for more intensive early intervention and therapies and support for risk of alcohol exposure. And then this will be another topic that we'll come back to with interaction with social services and these complications of the testing and interpreting the testing, because it gets very confusing for people. Okay, here's a scenario that I feel like I've heard people tell me about when I've gone out in the community. I gave a talk up in northern New Mexico, and they talked about women who will not disclose use, even when their drug screen is positive or the baby is positive. There's not disclosure, there's not communication, there's denial, there's fractionating, splitting of the care team. But they have concerns about substance use, either because the tests were positive or maybe there was no lab tests that were positive, but the behavior of the family seeming like they're overly sedated, or they're leaving the unit, or they have track marks, or you find them with drug paraphernalia in their room. These things happen, and they still sometimes do not disclose. So that's really challenging for a care team. And so that, I think, it should be a moment when everyone in the care team should probably just take a few steps back, try to extract themselves from the emotions of the situation and see what we're missing, because we're missing something for that family. They don't feel safe disclosing what's going on with them. Maybe there is complications of criminal justice involvement. Maybe she's scared of somebody in her life. Maybe she doesn't feel like that she has the privacy. Maybe this community hospital has too many of her relatives working in it. Maybe she doesn't have transportation. Maybe she's trying to sneak out and take care of another child. And so it's important to just everyone pause and then see what barrier there is to communication with the team, because it doesn't mean that this person is bad or evil. It means we're missing something for them that we need to check in on. And then coming back again to talking about what's best for your baby, and let's try to work at taking care of your baby. Okay, so now we're at the step where we've identified the baby through history or laboratory studies as a baby who has prenatal opiate exposure. So now we're at the observation and assessment section of their care. At this point, you plan for a 96-hour hospitalization for observation and assessment. So that is the recommended length of time, because 98% of babies who have opiate exposure will express clinically significant opiate withdrawal by 96 hours. A few babies rarely will express it up to 7 days after delivery, usually with moms who are maintained on methadone. So we should plan for them to be inpatient, and we should start scoring them to see what severity of disease they're going to have. And also, while we're doing this piece, we should remember that not all infants are going to need pharmacologic treatment or a hospitalization beyond 96 hours. It's really going to depend on the baby's metabolism and genetics. And we're finding more and more about different genotypes that put babies at risk for really severe withdrawal. Soon we'll probably be able to risk stratify infants by their genetic profile. From the very beginning of a baby's life, we really should be pursuing the non-pharmacologic treatments that help babies. And we're going to have a whole lovely talk about this, but we were just discussing that these treatments really fit in with baby-friendly principles and advocacy of early breastfeeding. Breastfeeding will also be another topic too. So, but basics are skin to skin, swaddling and understanding infant cues. If we can do that, we also decrease the number that need pharmacologic treatment. We don't know what exposures will put a baby at risk for more severe withdrawal, but we do know that some exposures put the baby in a lower risk category. In fact, if moms are maintained on Subutex through their pregnancy or buprenorphine, then it's starting to look like only about half of the babies require pharmacologic treatment. So that means we could have half of these babies that we've identified not need any further hospitalization after that initial 96 hours. So when you're assessing these babies, we're going to recommend that everybody use the Finnegan tool. It was created in 1975. It's really the most widely used tool worldwide. There actually is no real evidence to say that it's better than the other tools, but it's just very commonly used. It's only intended for term infants, so you'll find that if you have a baby who is born less than 37 weeks, it's probably not going to be applicable for their neurologic development. And also they should be less than 30 days old, because once they're too old for this, then they have their own set of personality traits and cycles that don't match up with the Finnegan tool. Some components of the Finnegan tool are very subjective, and you'll see when we talk through them. Some are objective, so measuring the baby's temperature or how long they sleep, those are objective measures. And then quantifying how jittery they are is a little more subjective. So that's those are some of the limitations there. And also, we use the tool to try to reflect a baby's presentation over about 2 hours, but they'll cycle through many of these states during that time. And so you're sort of trying to take an aggregate, and so it can be, you can weight it more towards the negative if a baby, and so it's very challenging to really do a consistent, precise Finnegan tool measurement. So it's one half subjective tool that we use to assess babies, and it'll be one tool in your toolbox for taking care of these babies. It'll be a piece of our puzzle, but it won't be the definitive answer to what babies need. If you know that, it makes you feel better, because people get stressed out about different people scoring different ways, and so it is subjective, and we should if we recognize that, we can do a better job. So we ideally will be scoring the baby about every 3 to 4 hours, and also ideally not waking the baby up and pulling the baby off mommy's breast and yanking the baby out of the mom's arms and putting them in the bed and wrestling them around to do the scoring. So we try to do cluster cares when a baby is awake and needs a diaper change, or is with the mommy. We can assess the baby with the mommy in her arms, because we'll get falsely elevated scores just by harassing babies. If we harass neonates who are not opiate exposed, they'll get high scores too. So. Okay, so hopefully you have the handout of the Finnegan tool with you as a printout, and you'll see that the Finnegan tool is divided into 3 categories. The first being the central nervous system disturbances, and then vasomotor and metabolic symptoms, and then gastrointestinal. All of these symptoms reflect kind of the acute physiologic dysregulation that babies experience from opiate withdrawal. But some of these symptoms are kind of the long-term changes that happen for neonates when they have prenatal opiate exposure. So they're not as responsive to treatment, and probably shouldn't be weighted as heavily and when assessing babies. Okay, so what we'll do is, since the Finnegan tool is going to be kind of the basis of our assessment of these babies, I'm going to spend a little time going through each of these categories with you. But you should also know that it's really is a matter of practicing with real babies, with another rater, with experienced score givers, and repeating this process over and over, and trying to get comfortable with using the tool. So the first section with the central nervous system disturbances, most of these are expressions of really discomfort, but also expressions of decrease in dopamine in the baby's brain. So the high-pitched crying, we assume that there's a component of just plain suffering, of being very uncomfortable with withdrawals. Adults report that they are very achy and just they feel terrible. But there's also probably a neurologic dysregulation that causes babies to have this high-pitched cry that is also related to just physiologic disorganization. And so if they're crying for greater than 5 minutes, continuous, they get a greater score than excessive high-pitched cry for less than 5 minutes. So again, they're fairly subjective, like what's the difference between continuous and excessive. Then there's a measure of sleeping. Sleeping for a neonate is, we think, is pretty important for their brain development. There's probably a lot of neurologic growth and change that happens during infant sleep, and so sleep is a really important goal for these babies and something we should watch closely. So if I were to put a little star next to one of these measures, it would be the sleep one. Then the next one is the moral reflex, and you know the moral reflex is this movement, the startle movement that's symmetric for babies. And a hyperactive would be maybe more than 3 or 4 beats. And then there's markedly hyperactive. So it's that's another subjective measure between the two scores. Then there's 3 measures of abnormal muscle movement. There's tremors, myoclonic jerks, and generalized convulsions. And actually, these can be very tricky to differentiate for babies. And generalized convulsions, obviously, they're talking about seizures, and that's something we don't want to miss for a baby who has, for a neonate. A neonate with seizures is an emergency. So, but tremors, we would talk about fine movements of the distal body parts, and they can be stilled when you hold the baby. So, and then this is also kind of a subjective measure. The increased muscle tone just means that the baby is tight. And so when you pull the baby's hands, they can hold their head in midline, and that's not normal for a neonate. They should have some head lag. Increased muscle tone, though, is one of those measures that we were talking about where this is actually a chronic change for babies who have opiate exposure, probably similar to the way Parkinson's causes rigidity, the decrease of dopamine in the motor cortex, so in the motor section of the brain. So this, it doesn't change with treatment and probably shouldn't be weighted as heavily as some of the other features. Babies who have excoriation, so the areas where they are sort of rubbing themselves. So they'll rub their chin with their hands. They'll be rubbing on their knees, their toes, or their extensor surfaces, and we think probably they're feeling itchy. Adults who have withdrawal feel itchy, and so they're probably rubbing themselves. Myoclonic jerks are, if we talked about tremors as being the fine movements of the distal extremities, myoclonic jerks are bigger muscle groups that do sort of a twitching jerking. And usually myoclonic jerks are when a baby is changing some level of their sleep cycle. So they're falling asleep, and it looks like when you have a falling dream and you jerk yourself awake, it's probably the same process. So if you see a baby who seems to kind of jerk themselves out of sleep, that's a myoclonic jerk, which is also really difficult to sometimes to tell the difference between that and a seizure. So they generalized convulsions, you cannot still them by holding the baby, and there may be other signs on the face of a seizure, and that's scary. You don't mess around with that. So hopefully nobody's scoring for babies, giving them 5 for seizures on this category. So that's the central nervous system set of assessments. And again, I think the most important 2 up there are the sleep and the crying. We don't want a baby suffering, and we want them to be able to sleep. And the next set are the metabolic measures. So a baby who is going through withdrawal is having metabolic demands in excess of what a normal baby has. And so they are have a higher calorie demand, and they are just hot and working hard. So they get scored for sweating and hyperthermia. And I would tell you all that if you have a baby who actually has a temperature that is a fever that is greater than 38.1, you should assess that baby and keep your differential open and make sure that you're not missing a baby with sepsis or another process happening. Especially HSV goes with fevers, and that can be devastating. So yes, a baby might be warm, but they really, if they are persistently febrile, then expand your differential and look for other causes. Frequent yawning, greater than 3 or 4 times in the interval is the measure. Babies with mottling, they're talking about sort of the marbleized look to their skin, and almost all neonates have that. So mottling, I think, is a really poor measure of this process. Nasal stuffiness is very consistent with babies with opiate exposure, and that persists as well into their first year of life. Sneezing, we score them if they get a score if they sneeze more than 3 or 4 times. All little neonates are going to sneeze because they have to probably get the amniotic fluid out of there. So usually they don't sneeze more than 4 times. So I think that's a reasonable score, but it probably is less important. Then the next 3 scores on this section are related to nasal flaring and having tachypnea, or a rapid respiratory rate with retractions. And I, again, would encourage everyone that if they have a baby who's showing signs of respiratory distress, to keep their differential open and make sure you're not missing pneumonia or another process. But babies with withdrawal can have tachypnea with a little extra work of breathing too. So that is definitely a feature of withdrawal. The last section is, and so going back to the metabolic section, I don't have any that I star in there. I think these are kind of helpful adjuncts to the score, but they are not the most important measures of how baby's doing. GI disturbances are important for their assessment. So babies who have opiate withdrawal will have, they're kind of hyperoral. So, and I feel like it's related to having high tone. They don't suck on the pacifier in a rhythmic pattern. They chomp and suck and suck and suck. And so it's sort of adults who have withdrawal symptoms also feel kind of hyperoral, like they want something in their mouth. So this can lead to overfeeding. So if you put the baby could take more, they just kept taking it. They seem to want more, and you'll put the bottle in their mouth and they'll drink 100 to 200 cc's in a feeding, and then they'll throw up, which exacerbates all of their symptoms. So we have to watch for excessive sucking and hyperoral and make sure we're not confusing that with being super hungry. The second section is poor feeding, and this is really related to being discoordinated. So they're just sort of out of order. They can't coordinate to suck on the bottle or on the breast very well, and they have a lot of poor feeding. That's a great one to put a star next to. That's a very important measure of how well we're taking care of a baby with opiate withdrawal. We should make sure that we are really helping them with feeds and treating their withdrawal symptoms so they can feed well. And then there's 2 measures for emesis, whether they do it greater than 2 times or if they have projectile vomiting. And again, I think projectile vomiting is a little subjective, but if they're having a lot of spitting up and GI upset, I think that's a good measure to have in there. Some babies will have a lot of loose or watery stools, and that's important to keep track of as well. But again, I think the star measure on there will be the poor feeding. So that's how you score these babies, is by looking at these and then filling out your Finnegan tool and adding up their scores. So it really does require practice, as you can tell. It can be difficult, especially the central nervous system section, to really try to discern between tremors and tone and these and myoclonic jerks, etc. So it really does require practice, and so that's why we're going to encourage folks who really want to advance their practice in using the Finnegan tool to come and do a mini sabbatical at our institutions with our providers who are really confident in their scoring. We also recommend that if you're uncertain about what your score for a baby would be, that you have someone else come over and do their score, and then you guys compare. And that will probably be part of our QI process, is doing some inter-rater reliability measures for the Finnegan tool. Okay, and then I have a video of a baby who is experiencing withdrawal, and we're not going to be able to do all the assessments for this baby because it's only 20 seconds. It's not 3 hours.
Mhm.
But take a look at your form and see which points you can give to this baby that you're seeing. And there is no sound on this video, just so you know. But the baby's crying, high-pitched crying. So we're seeing a lot of those movements
Yeah.
that we talked about, and
The
see,
distal,
yep, the distal kind of fine tremors. And then some of the bigger movements, although I don't think he is, yeah, take a look. I don't think he is actually transitioning between states. Will you play it again? Like he's certainly in the state of active crying, so he's not transitioning into sleep or out of sleep, but he's having some of the bigger muscle movements that look a little rhythmic. And then he looks like he's tight to me. He just is holding himself very flexed. I would predict that he
It's
has,
kind of like,
increased muscle tone
yeah.
and crying. So we could score him for a couple of those things just from looking at him. Now,
But you're right, you have to have a careful eye to really watch those distal extremities. You know, because babies do that.
Right.
Anyway.
Yes.
But it's like this last, like, little, like the
Yep.
beats that you described.
Yes.
3, 4, you know.
yes, and
Okay.
and then also look where he is too. He feels really stressed out. He's unswaddled.
Yeah.
He is in that little crib, and so he's lonely too there. So we try not to score for loneliness. So we try to make a baby know that they're not lonely when you're scoring them. If you can, it's tricky.
So you mentioned, just a quick question, you mentioned like try to do it when mommy's holding the baby so they have a little bit of comfort, because as you mentioned, you can't score the lonely factor.
Yes.
So then if mommy's holding baby and they're not in this kind of disturbance state that they would be in their bed, then how do you monitor for that piece?
Yes. Well, it would be nice if we could easily transition them from mommy holding very gently to lying in the crib. What we're not seeing from this baby is not in quite alert state. So neonates will be able to spend time where they have their eyes open, they are moving, but they're not.
It's fluid.
It's fluid, exactly. They're not having tremors. They're moving around and looking around and able to listen and take in different stimuli that's around them without ramping up into high-pitched crying and these movements. So if you have a baby who can move into the crib and can sit in the quiet alert state easily, and then maybe gently transition into one of his other states like crying, or then you feel a lot better about their clinical presentation of withdrawal. But I know I said to do it in mama's arms. How do you do that? It's tricky because we do have to try to score them, right? And see all of these features. So we just try to do our best.
That's why that practice piece is so important, right?
Yes. And part of nursing and provider care for neonates is to really get good at cluster cares and how you handle infants. And a normal infant, normal newborn should have a score of about 3 or 4 on this scoring tool from time to time. So if you know that, then that's what you can aim for. You can try to see if they're going consistently above that. Were there other questions about?
Dr. Bradshaw?
Yes.
Do signs and symptoms of NAS and their subsequent scoring change as the baby gets older? So say, would a 5-day-old be different than a 2 to 3 week old who are still obtaining scores on?
That's a great question, Jen. And theoretically, this tool should be good for up to 30 days for a term baby.
Okay.
But say you have a baby who was preterm, who was born at 36 weeks, and didn't have that high of scores for the first week. And then their brain matures, and at 37 weeks, they start expressing a lot more discomfort and a lot more stress, just because they have enough of the gray matter. They have all the connections in their brain to actually show us that they're having withdrawal. So I'd say, Jen, like most things in pediatrics, it depends. Okay. So, but yes, that is a possibility. The other thing, Jen, I would consider for that baby is if there's polysubstance exposure. So a baby who has worsening like higher scores in the 1 and 2 weeks of their life may be showing withdrawal from an SSRI, because we know that SSRI medications, babies will have tremors and myoclonic jerking and these other central nervous system disturbances at about a week to 2 weeks. So gestational age and polysubstance exposure can change that picture. So yeah, like it depends. Sorry, Jen.
Thank you.
Yeah.
Thanks.
Other questions?
I do have other questions, but I could ask them at the end.
Okay, sounds good. Coming back to doing the Finnegan tool, I think it's a really powerful message to parents that they are an integral part of the care team. If we give them a copy of this tool so they can look at it and see what we're looking for their baby, I think it also really allows them to be empowered to watch their baby and address the symptoms and care for the baby. And also if you're having trouble with your relationship with the family, this is a great way to bring them in and have them participate in when you think that the score is high and they don't, sort of what everyone is seeing. I think when we say we're going to score the baby, it almost sounds like we're giving the baby a grade and that we're being punitive and that we're punishing or we're grading down a baby if they get a bad score. So if you can bring the parents into the process, then it really can help communication and care for the baby. And then as we talked a couple things about on this scoring sheet, including the fever and respiratory distress and seizures, I think it's very important that while we're caring for these babies, and this was part of your question, Jen, too, if we have a baby whose symptoms we're not addressing well, we better step back again, reassess where we're at, and make sure we're not missing anything. Are we missing some other exposure like SSRIs? Are we missing something bad like sepsis, hypoglycemia, hyperthyroid? Are we doing the correct care for a baby based on their actual gestational age? And then sometimes there's just a feeling that this baby is suffering, and we need to alleviate their suffering, whatever their score is. So their score may not be meeting criteria, but we as a team and the parent feel that the baby is suffering too much. And that's our main goal, is to alleviate suffering and prevent complications. So always it's good to reassess where you're at, both with the social aspects of the family as well as the medical differential diagnosis for the baby. So then we're at the end of our assessment part of the care for the baby. We've observed them and we've assessed them and we're scoring them. And so if we are concerned that we have 3 consecutive scores of 8 or more, or 2 or 3 consecutive scores that add up to at least 24, that might indicate that the baby needs pharmacologic treatment. So that will head us into the pharmacologic treatment arm of the care for the baby. If we get to 96 hours and we have not reached that threshold, then we assume that baby is safe for discharge home. And then we'll talk about what to do for discharge planning and long-term care of these babies. So that's the end of this part of this curriculum. So Jen, did you have other questions?
I did. Thanks so much, Dr. Pratt-Chavez. There are a few questions that I'd like to ask. I think it was interesting how you brought up how we need to not just look at the baby, but also take the entire family or the mom into play. And something that I've noticed here with CYFD workers or social workers it seems that they don't know about the sensitivities of these urine drug screens. And so sometimes they'll say, for example, oh, the urine drug screen was negative, this baby's fine, it's safe to go home, when mom is still abusing, or clearly the baby's starting to have signs and symptoms of withdrawal. So I wonder if New Mexico will maybe implement with other providers or social workers or CYFD workers the sensitivities of some of these lab findings.
Yeah, that's a great point, Jen, actually, and that will hopefully be part of education about the utility of these laboratory findings, that they are not definitive tests that demonstrate absolutely whether a baby has drug substance exposure.
Okay. And then I have one more.
Yeah.
I don't know if this is going to be talked about in your next series of discussions, but I was reading in that because a lot of these babies are getting formula fed or not getting breastfed because mom is either still on methadone per se or buprenorphine or something. But I was reading that the concentrations of methadone or buprenorphine are actually pretty low in breast milk, and some studies even showed that it decreased your risk of NAS and hospital stays. And so is there a vision to maybe incorporate the idea of breastfeeding into some of these moms versus just entirely excluding it?
Oh yeah, I'm so glad you asked that, Jen, because we're going to have one whole unit about breastfeeding and substance use disorder.
Okay.
And you're right about the small quantities of these maintenance medications that go into breast milk. So if you have a mother who's getting treatment for her substance use disorder and she's using methadone or buprenorphine for treatment, we really do advocate that she have breastfeeding supported and that she breastfeed her baby. And you're right, it improves the baby's outcomes. And we feel, we don't have evidence currently, but we certainly have the gestalt that it improves outcomes for moms as well. Yes, that's a really good point, in that babies who do get to have breast milk have decreased symptoms of withdrawal and have shorter hospital stays. So we really would like for that to be part of their care. Oh, and also, Jen, when you asked me that question, you used the term neonatal abstinence syndrome, and that reminded me that I wanted to address the terminology really quickly. So neonatal abstinence syndrome was part of the Finnegan tool in 1975. So that I said she, I'm not sure if it's a she. The description of this syndrome was called neonatal abstinence syndrome, and it was supposed to characterize infant withdrawal from medications. And it is still widely used to describe infant withdrawal. So you'll see NAS, or neonatal abstinence syndrome. For this project, we are using the terminology neonatal opiate withdrawal syndrome, just for slightly more precision of what syndrome we are describing. So it is essentially equivalent to NAS when NAS is applied to opiate withdrawal. So, and I think NOWS has a little more clinical precision than neonatal abstinence syndrome. So I think you'll start to see in the medical literature that probably the term NOWS will be used more than NAS, but currently NAS is the also widely used descriptor of this syndrome. And was there anything else, Jen?
I think that's it for now, but I'm sure I'll have more coming up soon.
Okay, good. Thank you for logging in today. I appreciate it.
No problem. Thanks, Dr. Travis.
Make one more announcement. Go. So thank you everyone for joining us today. Again, this is, as Dr. Pratt Travis alluded to, this is one of many kind of talks coming up. So stay tuned. We have our next talk tomorrow. So take a look at our Envision New Mexico calendar for all of the Now New Mexico talks that are going to be coming up. We have one tomorrow, and then we have another one on Friday. So we hope that you can join us. Thank you. Thank you for presenting today.
Oh yeah, thank you for having me.